Thank you so much. The last talk just went a little longer, and by the time I ran up here, Dr. Bush was already talking, so that was great. I'm going to talk to you about pathophysiology of superficial venous disease. I'll try to make this simple and practical so that kind of give you a perspective of how to look at this from a point of view of day-to-day. We know superficial venous disease is not uncommon and it's not benign. What we all want is healthy, strong, good-looking legs. So we are designed to move, and we want to be able to move. If the blood doesn't get there, PAD, that's a problem. If it doesn't go out and it stays there, we have problems with that. The first thing to remember is, in terms of physiology, that we have a pump, the second heart, down in our legs. Our main heart pumps blood down, we got to get it up, and we've got valves along the way that work. If the calf pump is working well, then things work well. The second thing to realize is the superficial system versus the deep system. Believe it or not, I show these pictures to my patients and I explain it to them and give them the analogy of the carpet, the floor, the concrete floor, and water draining out, and along the way that we have valves. The definition of the term, we call it chronic venous disease, kind of the entire spectrum of disease, so to speak, versus venous insufficiency. And most of our superficial venous disease is from venous insufficiency, and whatever is a consequent of that is from hypertension. The two things to remember in terms of pathophysiology, the commonest factors that affect what we do day to day is, first is the valves are incompetent. That leads to reflux, which leads to venous hypertension. And everything that you see and want to treat and all the procedures that we're doing are all a manifestation of the venous hypertension. So the question becomes, if I see a telangiectasia, where's the hypertension coming from? I see an ulcer, where's the hypertension coming from? It's all a spectrum of that underlying problem, and to then find out, how do I trace it back? Why does this happen? We know family history, so it could be genetic. As we stand, we're fighting gravity, age, common in females, especially if pregnancy, if you're obese and not active, not working, all those issues. The second cause is obviously obstruction. So if you have venous obstruction, those problems will come in. So if the blood cannot flow out, it's going to go another way, causes incompetence, and you may get valvular incompetence secondary to obstruction, which is another thing. Now, regardless of what size, it is the venous hypertension that leads to all the consequences that you will see, and that, in my mind, is the most important aspect of understanding the pathophysiology. If you understand the pathophysiology in this regard, understanding the clinical patterns, very easy. Then how to treat and reverse this becomes very easy. And again, this is a picture I show all my patients in terms of what the telangiectasia is, reticular vein, what's subcutaneous, deep, how the different, and all of this is a manifestation of pressure from the deep coming up superficial, and the pressure being higher than it's supposed to be. If the incompetence is at the saphenofemoral junction, it's going to flood the whole plane. It floods the whole leg, and you get all the other issues. The hypertension leads to the edema, increased capillary permeability. Hemosiderin gets deposited because those red cells get out and break. When they break, the hemoglobin becomes hemosiderin. The hemosiderin is going to irritate the skin. You get a dermatitis. It irritates the fat and the skin. You get a lipodermatosclerosis ultimately. Finally, the tissues are not perfused enough. You get ischemia, and you then finally land up getting an ulcer. That's how the SEEP classification also progresses when you look at it. The other thing to understand is what part of the venous system is incompetent and where is the pressure high. I've seen patients who have just had reflux in the top segment get an ablation from the ankle all the way up. Not necessary, it's only the damaged part of it. So you examine from top to bottom, bottom to top, and you treat from top to bottom. So you kind of figure out the effects of gravity and map this out. So for every patient, at least in my mind, if not on paper, we're mapping out as to where is the pressure coming from and how is that working. Because oftentimes it could be the main valve that's incompetent. It could be one of the other branches that's incompetent. The saphenofemoral junction may be competent, and you have another large perforator in the thigh with the incompetent vein feeding and causing hypertension. So these patterns, and ultrasound obviously is the key to understand this, but if you understand this pathophysiology, then the treatment becomes very easy. The classification of primary versus secondary. Primary is when you get primary valvular failure. Secondary when it's secondary to thrombosis or some other problem. Perforators, the same concept. It doesn't always have to be the saphenous. You can have a valve fail in the perforator. That leads to hypertension in that segment and causes varicosities. Occasionally you'll see, and I don't see it as often, idiopathic deep valvular incompetence or a postphlebitic syndrome, AV fistulas, where those come in. So when you look at a telangiectasia, it's in the skin. When you look at a venulectasia, it's also here, but slightly larger. Then you go to the deeper reticular, and then you go to the varicose veins. All of this a manifestation of the pressure. So when the pressure has just started to go up, you get the SEEP1. Then it becomes SEEP2, more pressure, SEEP3, edema. Then you start getting into pigmentation. Then you start getting ulcers. If it's healed, it's 5. If it's still active, it's 6. And you'll progress backwards the same way, and you look for where exactly is the incompetence and where exactly the pressure comes from. This is just showing you again the way this progresses and how once you treat the underlying hypertension and the incompetence, how the skin heals and you get recovery. The second aspect to understand is the calf pump. And there to understand that walking is good. We are designed to move, and that we have pumps in our legs. So what are those pumps? You have a plantar pump, you have a calf pump, and what they call the foot pump, in that it acts like a piston. So if you see the heel-to-toe proper walking, I always tell my patients, because they think after procedure you just got to sit down and do nothing. You want them to be more active. And then they tell me I work out, but I just sit on even when they do the elliptical, they don't move their calf pump. So you try to get them to get their calf pump active, and it really helps. Standing in one place is the worst thing you can do to your legs because the pressure continues to go up. So activating the pump is a very important thing, and understanding that this physiology, when it gets abnormal, is pathophysiology, is what happens. So here's a slide of what happens when somebody's lying down. The pressure at the ankle will be 0. You elevate it, it's negative, the blood's flowing to your heart. As you sit up, from your heart to your ankle, you see the pressure starts to go up. That's in a healthy limb. If you're just standing, the pressure is the highest. As you start walking, that ambulatory pressure goes down. You stand again, it goes up. If you have perforator dysfunction or reflux, then that, when you start walking, it never kind of goes away. That's where compression therapy comes in. So how much compression do you apply? If you understand the pathophysiology underlying, that you're pushing back against the pressure coming from the deep, that's how you fix that. So when you look at unhealthy situations, the pressure will stay high in case of, for example, you have a May Turner or a deep obstruction. So you may see a patient who has an ulcer. You've treated the GSV was refluxing, some of this, but there still is something going on there. There still is swelling. You got to look for an obstruction deeper because the pressure has to be coming from somewhere. And that's one way to look at this and understand this. This is another chart that I actually love. So if you have a healthy subject, when they start walking, the pressure will go down. And then as you stand, just in one place, the pressure will go back up. That's a healthy limb. If you have superficial venous insufficiency, it will go down a little bit, but then go right back up as you stand. In deep venous insufficiency, that's why people with deep venous insufficiency get more pain when they're ambulating. And that's one of the reasons. And if you have obstruction, then it's the worst. It just kind of explains, you combine the anatomy with the physiology and how this all works, then it puts things in perspective. So try to make this practical kind of pathophysiology, if you would. So when you look at a limb and you say, okay, that's SEEP1, just got reticular veins and telangiectasias, what's happening here? You know there's a deep, something feeding and the pressure's gone up. The pressure's only high enough to cause telangiectasias and reticular veins looking large. As the pressure goes up, you're going to go to class 2, varicose veins. Then you're going to start getting edema. Then after that, you'll go into 4A and 4B, where you start getting pigmentation and atrophy blanche, as Ron showed. Then after that, you'll get a wound, and class 6, you'll have a active wound that's weeping as well. When you start treating that pressure and the reflux, you will see that the skin starts to heal, and it goes back in that same progression. So in summary, understanding the presence first, that there is venous hypertension. I've seen this time and time again. They just see a vein, they go fight for that vein, they see a reflux in the thing, a saphenous vein, ultrasound report says refluxing, and they're just shutting down the saphenous, while the main pressure is from a large perforator or the small saphenous or somewhere else. And patients come to us saying, I had these 3 procedures and nothing changed. So understanding that underlying dynamic, that there is hypertension, where it's coming from, is it obstruction or valvular insufficiency? Majority of the time, in what we see in superficial, it's valvular insufficiency. Which valves are insufficient? Which valves are failed? Saphenofemoral, saphenopopliteal, above, below, perforators, which one? So as you start working, as you examine from the bottom up, you start looking at the foot, swollen, what's happening, is there a wound, and you understand the pathophysiology behind it. Once you understand the reason for that hypertension, it becomes very easy to try to kind of figure out the pressure dynamics and come up with a treatment plan. Thank you very much.